health, everything you want to know, but you know how to ask. And my hope is that you will know how to ask some questions at the end of it, because I think that is the most interesting and fun part. Asking questions. Can everybody hear me?
No.
No.
Come closer.
The air conditioner is always there. Do you want to turn one of them on and see? We might both. Yeah. Let me see if I can do that.
Well, I will get started and try to talk loud, so we'll start from there. So the different types of sleep disorders that I'll just cover, I'll touch on some more than others, but sleep apnea is probably the most common sleep disorder I see. And then talk about restless legs, insomnia, hypersomnias, which are disorders of excessive sleepiness. You may have heard of narcolepsy, and there's something called CNS hypersomnia.
We can leave it off for now, and then if it gets hot, everybody, either one of these two buttons. I'm sorry, Doctor. Does that work for everybody?
Yeah.
Okay. Either one of these two. Yeah, either one of those two should work.
And then we won't talk about them so much today, but circadian rhythm disorders and parasomnias or sleep-wake transition disorders, and those are other disorders I deal with in the sleep clinic. So sleep, so it's not a static condition, but it's a complex series of events. So when you go to sleep, the world doesn't end, your brain doesn't shut down, a lot of things are going on. So there's 4 stages of sleep. So we categorize them into rapid eye movement sleep and non-rapid eye movement sleep. And non-rapid eye movement sleep has 3 stages. So stage 1 being the lightest stage of sleep, and then stage 2 and stage 3. And we call stage 3 slow wave sleep or deep sleep. And that is something that when people talk about restorative sleep, they talk about stage 3 sleep. Unfortunately, as we get older, that tends to decline, and sometimes it's not even present. So each stage is defined by a certain electrical pattern. So when I'm looking at someone's sleep study, for example, I'm looking at EEGs, which is how we tell the different stages of sleep. So this is a little bit what it looks like, a bunch of squiggly lines. This is what I read when I'm reading a sleep study. So the first one is just eyes open, very fast, and then it progressively slows down. And then REM sleep is a distinctive stage of sleep, and we can tell that when we're looking at the sleep study. But yeah, so just a bunch of lines is what I'm looking at. There are characteristic changes in muscle tone, breathing, eye movements during sleep, and that's how we're able to score. We look at brain activity, muscle activity, eye movements, breathing, oxygen saturation, and we also look at rhythms with the heart, so we put an EKG on there. And this is what somebody very peacefully looks like getting a sleep study. They look so happy and content there. But you do have a lot of stickers on your head because we're measuring brain waves, airflow. You'll be wearing some belts like this gentleman is here. Most people have a smile on their face when they're at our lab, like the lady up there. So let's see. But this is what it looks like when I get a sleep study and when I'm looking at it. So it's a bunch of waves, and those are brain waves, EKG, breathing patterns, and so that gives me a lot of information about when someone falls asleep, what stage of sleep they're in, and their breathing patterns, muscle movements during sleep. So I'll talk about sleep apnea because this is, again, the most common sleep disorder I deal with, and it has a lot of serious consequences. So this is something that we've known about for a little while, but it has come into mainstream media attention because of all of the adverse outcomes. So what is apnea? Apnea means pauses in breathing in Greek, and so this is when repetitive episodes of pausing because of airway collapse. It can be, we don't have great estimates, so it's at least 5% of the population, but other studies show 24% of the population. It does change. As we age, it gets worse. And also, women are usually protected before menopause, but after menopause, it increases to the level of men. So men at a younger age will get apnea, women will get it at a later stage in life. So this is just kind of an illustration of what happens with breathing. So the top one is just unobstructed breathing. You can see the red is continuous. As you go down, there's partial obstruction, so there's some sliding of the base of the tongue back, And partial obstruction or snoring just means there's tissue in the way of airflow. So snoring doesn't always mean apnea, but it does mean there's some tissue there. And obstruction is either when there is a full collapse or a partial collapse of the airway that prevents enough oxygen from getting to our vital organs. So this is just a graph. Sleep disorder breathing and aging, unfortunately, as we get older, we're more likely to have that. So what are the symptoms of sleep apnea? The most common symptom is going to be excessive daytime sleepiness. Falling asleep reading, watching TV, maybe you're at the computer or a boring meeting. I hope nobody's falling asleep now, but so an inability to stay awake, and you may also have frequent awakenings. Other things that usually bring attention to this are very loud snoring. You wouldn't believe how many people don't believe they snore. It's an accusation I hear every day. Oh, well, I'm told I snore. So that's very common, and people will actually see other people stop breathing. So you'll see somebody, and they'll have a pause, and then they'll gasp for air. If that has happened, and someone's told you that, you should be seen. Because by the time someone's seeing it, it's pretty pronounced. Other softer signs or symptoms are bruxism or clenching of the teeth or grinding. What that does is opens up the airway just a little bit so it can be a compensatory mechanism to have more airway space. Some people complain of dry mouth, morning headaches, erectile dysfunction, and men and women will get up with excessive urination, so getting up 3 or 4 times to urinate just at night, if that differs from your daytime symptoms, may be a sign. So untreated apnea, we know that it's associated with heart attacks, strokes, diabetes, hypertension, Alzheimer's, dementia, arrhythmias. We're even linking it to cancer because it causes an inflammatory response. So I just say, if someone was choking you 24 times an hour all night, your body has a reaction to that. It's in a state of emergency. And so that's why we care so much about apnea, not just because of the loud snoring is disruptive to everybody, but because of the health consequences. So next I'll talk about some of the treatments. So you may have heard of something called CPAP, or it's called continuous positive airway pressure. Has anybody seen someone wear a mask? Okay. So what this does is it forces a column of air into that airway so that it splints open and can't be compressed. And these people all look very happy in their masks, but that's not always the case. So masks are very hard to fit. So there are other options for treatment. I'm going to tell you about some of those. Some of those work better than others. So oral appliances, surgery, and other conservative measures. And we do have some newer technologies that are coming out that may be of benefit. First thing I'll show you is the second most common treatment, which is an oral appliance or a mandibular advancement device. And what that does is it moves your lower jaw forward, and that helps create more airway space so that that soft tissue can't collapse back in the airway. This is generally used for people with more mild to moderate symptoms, and it's less effective the more severe that apnea gets. But it can be more comfortable for some people than wearing the mask on their face, is to have this custom made by a dentist who generally specializes in doing snoring and sleep disorder breathing. Then there's surgical correction. So this is, performed by an ear, nose, and throat surgeon. They remove the uvula, some of the soft tissue. It can be a series of surgeries where they, correct deviated septums. It has a variable rate of success, so it depends on the surgeon, the type of surgery that is recommended. But basically, as you can see in the picture, they're kind of removing some of that excessive soft tissue, so hopefully there is less collapse in the airway. Other conservative options, so weight loss. Weight loss is always going to make apnea better, but weight loss doesn't always make apnea go away. So sometimes people lose a significant amount of weight and they can make their apnea go away, but sometimes that doesn't work. Weight loss, it's always part of the plan. You have to know that weight gain always makes it worse. So that's the problem. The problem with weight gain is it also worsens the apnea, which makes it easier for you to gain weight. So it's a vicious cycle. So sometimes I have patients who had come to me and they say, well, I don't eat very much, and it's like, oh, I don't believe you at first. And then I realized that, in residency, some of these people really had sleep disorders, and that was what was preventing them from being able to lose weight or accelerating their weight gain. Sometimes treating, severe nasal congestion can help with snoring. Occasionally with apnea, though it's less helpful. Exercise to lose weight can be helpful. Positional therapy is something that we use. And that's because most people tend to snore more on their back and have more breathing events. And that's because gravity is pulling soft tissue into the airway. So we go to sleep, our muscles relax so we don't act out our dreams, and that soft tissue can fall back in the airway, worse on your back. If we have you sleep on your side, then there's less soft tissue in the airway. So there are belts that you can buy, inflatable belts, belts with foam, snore ball t-shirts. So we'll have people wear those to help them learn to sleep only on their side, and that can help with snoring. So if somebody doesn't have apnea and just snores, sometimes that's what we will employ to help them. Other things you can do are avoid certain things that we know cause worsening of snoring or sleep disorder breathing. So alcohol is terrible for your sleep, and it causes, you may have noticed that somebody drinks a lot and they're snoring away. It's because of the muscle relaxation in the airway. It does a whole host of other bad things to your sleep, but in terms of that, it definitely causes worsening breathing and snoring. Other medications like benzodiazepines, Valium, Xanax, lorazepam, Ativan, those type of medications also are muscle relaxants, and they can cause worsening of snoring and sleep disorder breathing. So you'll want to avoid those, and sometimes people are on these medications or drinking a lot, and when we remove them, they have improvement of their symptoms. So I don't know how many of you have apnea, and maybe you do, maybe you don't, maybe you've heard of some of these things, but there's something called RIWHO, and I will touch on this, not because it's extremely effective, but just in case you had come across it. So these are stickers that people put on their nose, and instead of continuous positive airway pressure, it's negative pressure. So breathing out kind of helps expand the airway. It has a variable success. So some people with very mild symptoms may do well with this. But you're taking a sticker and putting it on and off every day, and it's not 100% effective for a lot of people, so it's not generally something I recommend, but it's something that's out there that you may have questions about. Another novel device is something called the Winks. This is something that goes in the mouth, and it works as a suction. So it pulls the tongue forward, and what that does is creates more airway space, as you can see in the picture. Now, this only has a single setting, so it's not going to work for a lot of people, and it can't be, moved, for individual preference or for treatment. So, but it's something that's out there. People ask me about it. They'll come in all excited that they found something, and so I have to go over those. This is the newest in our line of treatment options. It's a hypoglossal nerve stimulator. So it goes underneath the chest on the opposite side of a pacemaker, and it's an implantable device, and it hooks to the nerve that is connected to the tongue. So it moves the tongue forward, and it's supposed to sync up with respiration so that it moves the tongue forward as someone's taking a breath at the time that they would be having a breathing event. We just implanted our first device recently at Cornell, and we activated it last week. So we'll see if this particular patient does well with it. There's about 400 worldwide, so there isn't a huge population of people that have this, but it is a novel therapy, and it may be appropriate for people who can't tolerate other therapies and have severe apnea. So restless legs. So restless legs used to be something that people just thought they were crazy. Oh, my legs move all the time. I can't stop moving my legs. But restless legs is something that typically occurs at night, so it follows what we call a circadian pattern. So circadian rhythm is our master clock, tells us when to go to sleep, when to wake up. It's also in charge of virtually all our hormones and those type of things. So it happens at night, and it's typically worse with inactivity or when you're lying down and you notice it. It's typically helped by movement, or distraction. So someone will get up and feel like they have to walk, they have to move their legs, moving them back and forth. And that can be a symptom of restless leg, and it varies. So some people may have it a couple of times a month, a couple of times a year, may have had it during pregnancy and never had it again, but it can vary. And these are some of what people will describe: pooling, creeping, crawling. There can be a painful variant or tingling. Again, it's typically the lower extremities, but it can affect the whole body. The reason it's so bad is because it can be very debilitating in terms of quality of life, and it can interfere with the ability to go to sleep because it's a nighttime symptom. Some people will be unable to initiate sleep if they have really bad restless legs. There's even been cases of suicide because it went untreated because they just couldn't stop. So difficulty falling or staying asleep could be the symptom that people come in with. They're saying, oh, I can't fall asleep, and they're like, oh, well, tell me about your legs, and then they haven't heard of it, and that can be something that we can address. There's also new data coming out that it can have cardiovascular consequences, meaning heart attacks, strokes, high blood pressure, that have been associated with restless legs, and that varies, again, on severity and other medical problems that someone may have. Now, cousin of restless legs, and something people tell me, they'll say, oh, my doctor told me I had restless legs on my sleep study. Well, no one can tell you you have restless legs on your sleep study because it's a diagnosis that's only a clinical diagnosis, meaning it is a symptom, it's not something that we can see. What we can see on a sleep study is something called periodic limb movements. And these are rhythmic jerks that occur every 30 to 40 seconds throughout the night. And this can cause awakenings or fragmentation of sleep. And about 80 to 90% of people with restless legs have periodic limb movements in their sleep. There are people who have periodic limb movements who don't have restless legs. This is the second most common sleep disorder that we find on a overnight sleep study. Aside from sleep disorder breathing, we find limb movement. So somebody may have 50 an hour and be waking up very frequently from them, and that can cause daytime symptoms of sleepiness, decreased concentration, fatigue. Those things can be very debilitating in terms of daytime functioning. So that's interesting. Now, restless legs, there are medications that we can use. I'm not going to go into medications because that gets a little bit too detailed for us today, unless someone has a specific question about it. But I will go over some of the conservative therapies for that. So avoiding alcohol. So if anyone comes away from anything, it's probably don't drink before you go to sleep. So that makes restless legs and periodic limb movements worse. Caffeine and nicotine also worsen those. So a lot of people, that are above the age of 60 will have some periodic limb movement, so this applies to you. So if you drink a lot of caffeine or alcohol or smoke, that can worsen your nighttime sleep for a variety of reasons, but also because you may be kicking. So there is something that's a non-pharmacological treatment, meaning it's not a medication. I like, treatments that don't involve medication because they don't have side effects generally. This one is something called a Relaxis pad, and it's newly approved. Basically, it provides counter-stimulation. So your legs feel weird, funny, you lie on the pad, and it stimulates and distracts away from your symptoms and hopefully allows you to fall asleep easier and reduce your medication burden. So one less medication is good. Other things that I tell people to stop are antihistamines, if they can, because those can also worsen restless leg symptoms. There are medications like antidepressants, antihypertensive medications that can worsen restless legs. Sometimes you have to be on them, and we will treat around it. So sometimes we don't have a choice about that. Other things you can do, taking a hot or cold bath can be helpful. Massage can be helpful. Some people have had success with acupuncture. Exercise is something that is actually very helpful. So the more you exercise, it's not right at the moment that you have restless legs, but earlier in the day can help reduce your symptoms. And sometimes stretching before bed. Disorders of excessive sleepiness. So who here is sleepy? I've been sleepy before, but so narcolepsy, you may have heard of that. It's dramatically displayed in the movies. Somebody falls down and goes to sleep. That's not exactly what's happening. It's another spectrum disorder, and the hallmark of it is excessive sleepiness. They can fall asleep, driving, watching TV, at work. So it varies in severity. Some people have a hard time staying awake, talking to another person, or a lot of people, if they're actively doing something, won't. Other hallmarks of sleep paralysis, that is when you wake up and you feel like you can't move anything but your eyes. And what's happening is you're coming out of rapid eye movement sleep. And when we're in rapid eye movement sleep, we are paralyzed, except for our eye movements and our diaphragm. So we can still breathe and we can move our eyes. But if you wake up out of that suddenly, and you can't move, and it takes a few minutes, that's sleep paralysis. So that is very common with narcolepsy, but it has happened to probably 60% of people in this room. Sometimes sleep deprivation or something like that will trigger it. So certainly as a resident, when I was on call the next night, I had a few of these happen. They're not fun. The other hallmarks would be hallucinations when waking up or going to sleep. That can be part of that dream state and that misperception there. Cataplexy. So that's what you hear when someone falls down and goes to sleep. Well, they don't actually fall down and go to sleep. They may fall, but it could be something like dropping a pencil or a drooping of their mouth. And it's typically brought on by something startling. They think it's funny or they get angry. So high emotional content. And it's actually that they lose muscle tone because they're having intrusion of dream sleep into wakefulness. So that muscle relaxation that we have during dream sleep happens in wakefulness, and they may fall. And if they're on the ground long enough, they'll fall asleep, but they don't just fall and go to sleep. So that's how it's usually portrayed in the movies, that somebody just talking and falls down. Other disorders of excessive sleepiness, one is idiopathic hypersomnia. What does idiopathic mean? It means we don't know. There's no real explanation for it, but we have a lot of patients that have excessive sleepiness and there is no other cause. And we do special testing for narcolepsy and idiopathic hypersomnia to differentiate that from, I'm fatigued and I feel tired versus the ability to actually fall asleep very frequently. But the worst culprit of all is insufficient sleep. So I've heard this a lot. And that's what you will look like if you don't get enough sleep, unfortunately. Insufficient sleep, there typically is a dissociation between perceived sleepiness and actual sleep debt. So people that have been sleep deprived sometimes will say, oh, I'm not sleepy at all. But their reaction times or cognitive performance is impaired during that time. It's implicated in 40,000 vehicular crashes a year. So it's a big deal. People are falling asleep or nodding off even for a second while they're driving or operating heavy machinery. In New York, it's not as much a problem because we're a pedestrian city, but certainly there are things where you need sustained attention, and that can be a problem. It's linked to diabetes, cancer, depression, premature death, and hormonal changes and metabolic changes that cause weight gain. So basically what happens, you don't get enough sleep, your stomach starts releasing a hormone called ghrelin. It's just like, feed me. It's basically what it's saying. So it's this overwhelming need saying, I'm hungry. And leptin, which is our hormone that tells us that we're full, gets decreased. So you're getting an urge from your body to keep eating even though you're full, and that can be a very powerful urge. So you may have eaten, but you're still hungry, and it's because your body is programmed to tell you you're still hungry. You really need to sleep. So one of the fun things I get to do is say, part of your weight loss routine is to sleep more. So that's not the worst thing I can tell somebody about that. So that's good. Now the reason it's implicated in things like cancer, premature death, and diabetes is that when you don't sleep enough, our bodies have to go into overdrive, and that causes inflammation, okay, throughout the whole body system. It's hard on the body, you're overworking it, and it predisposes you to things like cancer. Your body can't fight infections or abnormal cells, which is in the case of cancer. Insomnia, now this is something that's hit by everybody in here at some point in their life. So it's a complaint. It's difficulty falling asleep. It can be difficulty maintaining sleep. So some people say I go to sleep right away, but then I wake up and I can't get back to sleep. And they also complain of chronic non-restorative sleep. I don't feel like I sleep well. And this occurs not because I give you 5 hours to sleep and you're saying, well, that's all I got, I have insomnia. It's that you have enough time to sleep. And the difference between somebody that just gets, not quite enough sleep and insomnia is that they have daytime impairment. So in cognition, in concentration, focus, or even sleepiness. It's one of the most common medical complaints, so primary care probably see it even more than I do as a sleep doctor. So I can't sleep, so up to 70% of the population has had a period of time where they've had some difficulty. That can be associated with stress. Are people starting to get hot?
No.
Okay, so women tend to report insomnia more than men for some reason. Women are the afflicted sex in this case. And so it's also more common in people going through emotional turmoil, divorces, unemployment, you're widowed, separated, those type of things. We can't separate, our day lives from our sleep lives sometimes. So what the complaints will be fatigue, poor concentration, mood disturbances, daytime sleepiness, headaches, GI symptoms, ongoing worry about sleep. So that's a very big complaint that I hear is I'm very worried about my sleep. If I don't sleep, all of these horrible things will happen, which is part of the problem with insomnia is a focus on sleep too. Drugs that can cause insomnia, there's a lot of things in our world that can cause insomnia. So stimulant medications, nicotine, diet pills, certain blood pressure medications can cause insomnia. Certain medications used to treat depression can cause insomnia. So, there's a lot of things that we have. Obviously, alcohol and caffeine, which we talked about, will, make insomnia worse. Again, I won't talk too much about medications, other than to say, there's several different classes of medications that we consider hypnotic medications, which are true sleep medications. And there are medications that we use for the side effect of sedation. And we use those less. So there may be certain antidepressants that cause sedation, or antipsychotics, or other medications that block histamine or have another pathway of sedation, and we may use those, but those typically are not first-line agents. Other treatments that we use are something called cognitive behavioral therapy for insomnia, and that is that divorcing of our automatic thoughts about sleep. So I'm not going to sleep tonight, I'm going to feel horrible tomorrow, everything's going to go downhill if I don't sleep. Well, that frustration is the worst thing you can do for your sleep. So part of cognitive behavioral therapy is getting rid of that automatic thought that you have connected to your sleeping, having better sleep behaviors, and dealing better with that stress. So, things that you can do to improve your sleep: avoid caffeine. That doesn't mean you can't have any. It just means, instead of 10, you have some in the morning. Timing, the time since you last drank caffeine is important. Also the caffeine load. So how much have you drank? If you drink 2 liters of Coke, even if it's been 5 hours, it's still going to affect your sleep. Nicotine is bad, whether you're smoking it with a cigarette or using lozenges or nicotine gum. So we try to push that away from bedtime. What I recommend is turn your bed into the kind of place where you look at your bed and you think sleepy. So you want it cool, dark, comfortable. You don't want to do any activities on your bed but sleep and have sex. That's it. You don't want any pets. You don't want to eat, because you want your brain to look at it like it looks at a cookie. So I look at a cookie and I think, that looks good. And I look at my bed and I think it's sleepy. But other people look at their bed and they think, oh, that's a place I'm going to get frustrated, or I talk on the phone, or I watch TV, or I relax, or I think about all my problems. And you don't want to cloud your brain with all of those things. So you want to make it a sanctuary. Establishing a bedtime routine that's soothing, because sometimes people will go, and then they want to go to sleep. They'll get home from work or whatever activities they're doing, they don't have a wind-down routine, and then their wind-down happens in bed, and they complain of difficulty going to sleep. So make sure that you have something that you routinely do that helps set the tone for your night. Go to sleep when you're tired. Generally, don't go into bed wide awake and be like, oh, I just hope I can go to sleep. I do want you to keep regular sleep-wake times, but I don't want you going into bed when you're wide awake or you just got in a fight with somebody. You're just going to hunker down and go to sleep. Sometimes that doesn't work. Don't look at the clock. That is something a lot of people with insomnia will do, is they will clock watch. And that is an instant access to anxiety. So you look at the clock, you have a visceral reaction to seeing that clock because maybe you have to get up at 6 o'clock and it's 3 o'clock in the morning and oh no, you have only three hours to sleep. Oh, it's 3:15 and you're getting yourself all frustrated and anxious, and that is the worst sleep medication I could prescribe. So if I was peddling that tonight, nobody would buy it. Use light to your advantage. So we need light in the morning to tell us it's time to wake up, and we need to avoid light in the evening. So a lot of electronic devices are backlit and they produce a blue-green wavelength of light that is stimulating to us. And it also decreases something called melatonin, which is our darkness hormone or our sleep hormone. So if you're on the computer really close to bedtime, you might find it more difficult to go to sleep and maintain sleep. So generally I recommend getting off of all of these devices, anything electronic, so that can be a Nook or an iPad. If you don't have to turn on the light to see it, it's electronic and you shouldn't use it. There are certain glasses that you can buy called blue light blocking glasses, and they're intended to help reduce the amount of blue light that reaches your eye and help reduce that. But I generally say if you don't need to do it, don't. If you have to for work or personal reasons, then getting these glasses, which generally run $15 to $20, may be a good investment. Keep your internal clock set with consistent schedule. So like I was talking earlier about a circadian rhythm, our master clock, every cell in our body has a clock, okay? And our master clock tells all our other cells what it's supposed to do. Now we can't shift our bedtimes very much and be able to fall asleep and wake up when we want to. So if you go to bed one night at 10 and then another night at 1, your body doesn't know when it's supposed to fall asleep. And so that is part of cueing your body and, you know, that you want to go to sleep and letting your body know when it's time to go up and keeping a consistent schedule. We can have some variability, 30 minutes, something less than an hour is typically okay, but when we go 1, 2, 3 hours, then we're crossing time zones and you can get what we call social jet lag from staying out late. A lot happens to a lot of people. They'll stay out very late and then they'll have symptoms the next day, fatigue, GI symptoms. So you want to make sure that that's pretty consistent. Napping, everyone loves to nap sometimes, but if you have problems sleeping, then you should not nap at all, or if you're going to nap, you nap for very short periods of time, 20 minutes, and you do that early so it doesn't interfere with your ability to go to sleep. If you're someone that says, well, I have to nap 4 hours during the day and then I have to sleep 9 hours at night, then you're too sleepy. So that's something to take into consideration. Eating evening meals. So anytime we fill up our stomachs and then we lie flat, all that acid can flow back because we're typically standing upright, but when we lie flat, that fluid in our stomach can fall back into our esophagus and it's irritating. And it can wake you up out of sleep. You may not know it, but it's fragmenting your sleep. So you want to, generally try not to eat 2 or 3 hours before bedtime. Sometimes you can have a little snack, but not a big heavy meal. Exercise early, so that can be early in the morning. The best time to exercise for most people will be between the hours of 4 and 7 in terms of our circadian clock, but anytime you can exercise as long as it's not right before bedtime is good. And I say not before bedtime, about 2 or 3 hours. Because if you exercise and run and then jump into bed, you're probably not going to go to sleep very easily. So that is my presentation, but this is my favorite time, which is question time. And this is where I just answer your questions. It's a lot easier than just talking.